Mike Gibson, Gregg Stone, talking to you about BRIGHT-4. You know, Gregg, the story continues. You know, it's been a decade, how long have we been working on Bivalirudin?
Gosh, it's probably been close on 2 decades.
2 decades of Bivalirudin. And, you know, there was the initial studies, but now a big question is, you know, what's the right dose after the procedure? So talk to us a little bit about what you found.
Well, you know, it's been interesting because, I mean, I was involved with this at the beginning. We ran Horizons AMI, which found a mortality advantage in addition to marked bleeding with Bivalirudin as an anticoagulant during primary PCI in STEMI compared to heparin. But at that time, we used heparin and 2B3A inhibitors. And so people started to say, well, what happened was that caused all the bleeding, and the 2B3A inhibitors are no longer necessary, especially as we're transitioning over to radial artery access and have dual antiplatelet therapy, et cetera. And in addition, we had a problem with Bivalirudin back then. Even though it reduced mortality, it had an acute stent thrombosis risk. And
early,
within the first few hours, actually, after the procedure. And we used to shut Bivalirudin off right at the end of the procedure. And it has a very short half-life, 25 minutes, and that seemed to be associated with kind of a rebound stent thrombosis effect. So over the years, there were actually 5 more large-scale trials that were done. Some in STEMI, some included non-STEMI patients. Some used Bivalirudin with a post-PCI infusion to try to mitigate the stent thrombosis risk. But sometimes they used the high-dose infusion, the same infusion in the cath lab, the PCI dose. Sometimes they used a low-dose infusion. And with heparin, they started to move away from the 2B3A inhibitor and use heparin monotherapy with the 2B3A inhibitor reserved for procedural complications.
And there was even a combo in there of some Cangalore with Bivalirudin.
A little bit.
Which turned out to be quite a good combo.
Which was a good combination, in Phoenix. So anyway, when you do a post hoc meta-analysis to try to sort out all these different regimens and femoral versus vascular radial access, et cetera, the 2 therapies that emerged as potentially the best to reduce both ischemic and bleeding complications were Bivalirudin with a high-dose post-PCI infusion for 2 to 4 hours, and heparin alone, with 2B3 inhibitors reserved in both groups for bailout with radial artery access. But they had never been tested against each other in a large-scale, adequately powered randomized trial, and that was the genesis for BRIGHT-4.
Where? How many sites? How many patients? What did you find?
So we enrolled a total of 6,016 patients with STEMI, only STEMI, undergoing primary PCI in China at 87 different centers. We enrolled those patients over about a 3-year period, which is pretty quick for 6,000 patients. And it was really a trial that was designed to isolate the effects of those 2 regimens. And the trial compliance was very high. We found that there was a slightly greater, first of all, as you'd imagine, the ACTs were higher in the Bivalirudin group than in the heparin group.
Do you ever worry about unblinding with that?
No, because they're not that much higher. And when you look at the medians and interquartile ranges, there's a lot of overlap. So it's not like they're 600 versus 300. But in that being said, it was an unblinded trial. It was an open label trial. All of these trials have been open label. But that, always led to concerns about more bleeding with Bivalirudin, which we've never seen despite the higher ACT. But the bottom line is the primary endpoint was the 30-day rate of all-cause death or major bleeding, defined as BARC types 3 or 5 bleeding, and that was significantly reduced in the Bivalirudin treated patients compared to the heparin treated patients. It was about a 35% approximate reduction, an absolute 1.3% reduction. So the number needed to treat to prevent 1 event within 30 days was 76, and it was highly statistically significant, like 0.007. And it was driven predominantly by a reduction in all-cause death. So there was a significant reduction in 30-day all-cause death, about a 1% absolute reduction, which was statistically significant. And there also was a reduction in BARC types 3 to 5 major bleeding from 0.8% to 0.2%, about a 75 or 80% reduction.
Can you disentangle the bleeding benefit from the mortality benefit? Are these related?
Well, they were related because if you looked, about 40% of the patients who had one of those major bleeds died. Okay, so about 80% of the patients who have a major bleed, of course, 90% stop their DAPT. And there was no stent thrombosis related to that, but very high mortality in the patients with a major bleed. But there also were ischemic benefits to the bivalirudin that I think contributed. And as a matter of fact, stent thrombosis was not only increased, but it was decreased with bivalirudin compared to heparin. So, you know, the 2B3 inhibitors were always effective with heparin with reducing stent thrombosis, because heparin, as you know more than anyone, actually activates platelets.
Well, activates the 2B3 receptor. Yeah.
Exactly,
So, yeah.
exactly. So
it's like that Tom Cruise line of, you know, you complete me.
You complete that, yeah, you completely. So the stent thrombosis wasn't bad with heparin alone. It was only 1.1%. But with bivalirudin, it was reduced to 0.4%.
Wow. And,
you know, bivalirudin has a, you know, it's very predictable, it's pharmacodynamics, and it also interferes with fibrin bound as well as serum phase fibrin. Clot bound as well as serum phase fibrin. So it really gets into the clot. And so it is very effective at preventing stent thrombosis. And again, the median 3-hour post-PCI infusion, there was no increase in acute stent thrombosis. In fact, there was a decrease both in the first 24 hours and between 1 and 30 days. So all of that, I think, contributed. There tended to be less acquired thrombocytopenia because there's no heparin-induced thrombocytopenia with bivalirudin. So there's a lot of benefits when you really think about it to the drug that led to a substantial mortality reduction.
How is this going to change practice? We don't see a lot of bivalirudin use now in the U.S., but in China, are they going to be using this more?
You know, in China, at a lot of the centers, it's already used a lot. And now that it's generic in the United States, the price difference is hardly anything. It's about $150 for a course of bivalirudin, you know, versus like $10 for heparin.
Well, but if you can get heparin sometimes.
Well, and of course, right now you're having trouble getting heparin. So,
and was the bivalirudin in this study the Chinese bivalirudin, or was it American?
It was a Chinese bivalirudin, but it's been shown to be bioequivalent to the U.S. bivalirudin.
Chivalirudin.
Well,
that's what we call it, you know. But bioequivalent. So that's fascinating. So do you see us having resurgence in the U.S. of bivalirudin?
Well, I think there should be. I mean, this is a very easy therapy to give, and not only do you prevent stent thrombosis, but you prevent major bleeding and mortality. And to just decide what, you know, to tell the research nurse in the cath lab what anticoagulant to pull off the shelf, that's a very easy decision to make to reduce mortality.
Who makes bivalirudin in the U.S. now?
Well, it's generic.
It's generic.
So it's made by several different companies. And again, its cost is trivial.
Yeah, fascinating. You know, you just wait long enough, you see it.
Well,
you know,
it took a long time to
the
do
dose.
the right
It's the dose.
study.
It's the right
to get the dose,
right.
To get the infusion, to avoid the confounding by not putting non-STEMI patients in, by not giving anticoagulants to both arms before you randomized. I mean, and by having only radial artery access. You know, so we get rid of all the criticisms that people had in the past.
20 years. You've been a dog with a bone with this.
Well, you know, you gotta, if you believe in something, you gotta
keep pushing.
Keep pushing it, man.
Great. All right. Well, thanks, Greg. And thanks to all of you for joining us here live from AHA 2022.